discussing is what is highly underestimated is weight loss, and it's very commonly forgotten. Many of these adults are obese, and there are studies which have shown that up to 10 to 15% of weight loss can actually completely cure the disease even without pharmacological therapy. So that's one point we really should emphasize. The case of a 47-year-old male who comes to us with sudden painless blurring of vision in the right eye for about 20 days. There's no other history. I'm just going to fairly quickly run through the cases so maybe Dr. Ashwin can also have comments. His best corrected visual acuity in the right eye is 2400, the left eye is 2030. He does not remember any episodes of having lost vision in the left eye, and basically has no complaints with the left eye. He had a relative afferent pupillary defect. Ocular motility was fine. Color vision was defective in both the eyes, and the anterior segment was normal. Now this is the fundus exam. So here we can see from what we've gone over so far that this really is dyschema. There's a grain of the non-fiber layer here. You can see the venous tortuosity. So this is basically dyschema in the right eye. And now let's look at the left eye. So the left eye is not really normal either. We can see clearly that this disc is pale, and there's not really much of a cup if we try to look for one. So at this point...
So I would just like to stop here and say that with this kind of history, what would you tell the audience, this process of dyschema, is it from the optic nerve, is it from the eye, or...
More than the brain. The dyschema is not that severe like we were discussing before. It's more of a clue. This typically has been described as a Foster Kennedy or a pseudo Foster Kennedy. That's what this is called, where we have a swollen disc in one eye and a pale disc in the other. Now the point here is we decide whether it's true Foster Kennedy or pseudo Foster Kennedy, and there will be certain clues to that. The primary clue will be that the swollen eye, that's the disc with the eye with the swollen disc, has vision loss. It's 2400, which means it's not papilledema or dyschema because of raised ISP. It's because there is a neuropathy that's causing this. So at this point, we went ahead and did the visual fields. The visual fields here in the right eye, here you can see that there's more of an inferior quadratic defect. The left eye also shows this kind of inferior defect, which here almost looks like an inferior attitudinal. And so what next? Would you image? Was the question. And the history, left eye had no cup and was pale, and he hadn't noticed that probably had a previous episode. Anyway, so we made a provisional diagnosis of NAION in the right eye, and like I discussed, vascular risk factors. It made our life a little easier because the patient came in with a CT scan done by the physician as well. So we were just plain safe there as well. And on systemic evaluation, we did find that he had hyperhomocystinemia and hypercholesterolemia. This is just the point I wanted to make, which Dr. Rashmi just made a while ago. We're seeing a large number of young patients with NAION, where it appears that homocysteine is the single factor responsible. We're seeing that fairly often, that the edema is fairly resolved, almost resolved here. So that's the other thing about NAION dyschema, it usually does resolve in 6 to 8 weeks. If this was true papilledema, may not have resolved.
The interesting thing I've noted is that when the second eye usually follows the visual outcome of the first eye. So if first eye recovers to 6 by 6, usually the second eye also recovers.
With history of was painless and gradual over the last year, as she said. Again, no pain, no trauma, no headaches, no non-systemic illnesses. Her visual acuity in the right eye was 20/20 parts. Left eye was no perception of light. She had a relative afferent pupillary defect, of course, in the left eye. The right eye color vision was marginally decreased. The anterior segment was normal. And this is how she looked. So remember, she's come to us with history of vision loss in the left eye. So this is the left eye. The left eye shows a pale disc, and now the right eye is swollen again. And so, like we were discussing before, this is true Foster Kennedy syndrome. This is where, sorry. So we did do a Humphrey visual field, extremely unreliable, didn't show any pattern. And this is the imaging. So she basically had a fairly large tumor extending from the clivus anteriorly, and it had. This is not a great picture. It had encased the left nerve. It was extending towards the right and causing pressure on the right as well. This is another angle scan here. Perilesional edema here. It's a fairly large tumor. It turned out to be a meningioma, and and patient needed surgery.
These two pictures show the importance of always doing an MRI of the brain with contrast. If this picture had contrast in it, this lesion would have become very, very hyperintense.
So just to summarize what we when you're unilateral disc edema with the brain is to the other eye, these are all the possible differentials, and we should take a careful look at the history and visual acuity to give us the clue. So we'll go on to the next case. So this is a 9-year-old boy who basically came to us with history of double vision for the last 4 days, and he had this picture here. You can see the esotropia. And the ocular motility was normal. Couldn't really find any deficits. And this is his fundus picture. So we have a 9-year-old who comes to us with fairly good vision, complaining of double vision with esotropia with this kind of a picture. So how many of you would go ahead and image?
Again, there should have been all hands up. Bilateral disc edema is an emergency. Please do an MRI imaging.
Imaging was reported as normal. So the MRI brain and the MRV was done, was normal. Again, here the point I wanted to make was, if we look carefully, this is a normal MRI, but it will give us some clues. So let's look a little bit at this area, and you can see here that there's a flattening of the globe. You can see that there is increased CSF. You can even see that here there's an increased quantity of CSF around the nerve. So there is no space occupying lesion, but these are clues which push you towards the other diagnosis, which is IIH. So we went ahead and did an opening pressure which was 40 centimeters, which is fairly high for his age, and reached the diagnosis of IIH. This is another interesting finding. He came to us a couple of hours after the LP was done, and esotropia was completely gone. So this does happen fairly often. Even with the single LP, it's enough to relieve the 6 nerve of his pressure and the ET. So we did investigate them systematically. This is important to do in children. There are many treatable, preventable causes of IIH, especially in prepubertal children. He was found to have vitamin D deficiency. Started on treatment for that with our pediatrician, and started on astazolamide. This is 2 months later.